Once again, thank you for inviting me to give this talk. So heart failure worldwide in Asia and the United States and Europe is becoming more common as the population ages and as people survive from a variety of cardiovascular events, heart attacks, hypertension, valvular heart disease. In the United States now there are about 6 million Americans with heart failure. In 2037 there may be 10 million. And as heart failure progresses, so as the functional class, which is a measure of exercise tolerance, as that gets worse, the survival declines. End-stage heart failure with optimal medical therapy has a mortality at 1 year that is about as bad as metastatic pancreatic cancer, worse than lung cancer, leukemia, or AIDS. So it is a bad disease, even with a lot of the therapies we have. And if you look at if you divide the population of patients with heart failure based on functional class, the class 4 patients, the patients with the most advanced heart failure, there are 250,000 of them. Now remember, I said that there were 5,000 transplants reported worldwide, 2,500 reported in the United States. So we will never be able to provide transplants for all the people with advanced heart failure in the US. And some of these patients may not be good candidates for transplant. They may be too old. They may have other comorbidities, renal insufficiency, peripheral vascular disease. But as heart failure continues to deteriorate, end organ function deteriorates, which we hope can be restored by mechanical circulatory support. So what do we have to offer people with advanced heart failure defined by the ACC and the HA as stage D? Transplantation I talked about, destination therapy with VADS, continuous IV inotropes, I'll talk about that in a minute, and hospice care. So these are the data for survival of stage D patients treated with IV inotropes, which is extremely poor, and at 1 year, maybe 20 to 25% of these patients are alive. And the only patients that we treat now with IV inotropes are patients who are on the transplant list. So the 3 ways that we use these drugs, these agents, these devices are as a bridge to transplant. That was the traditional early use to keep people alive till they can get an organ, which is becoming more and more important because of the organ shortage in the US. Especially big blood type O's need these devices to keep them alive till they can get a transplant. Or destination therapy. People who are not great transplant candidates for these regions. They may have a recent malignancy. We want to wait till we think that they're cured. And these are the Heart Failure Society guidelines for when to use mechanical circulatory support. This is destination therapy. People who are not candidates for transplant. And this is the bridge to transplant. So the very first device was a pulsatile device, the HeartMate I, which went in the left ventricle, went into this pump, and then went out in the cannula to the aorta, pumped externally by batteries. Came out in 1993, was used as a bridge to transplant. But then there was a realization that there were a lot of patients who are not great transplant candidates, and what do we do with them? So this was the origin of the REMATCH study, which I participated in when I was at my previous institution, Temple University in Philadelphia, where we took people with advanced heart failure on optimal medical therapy defined as IV inotropes. We randomized them to continue the IV inotropes or to get this device. This device has largely disappeared, has been replaced by this device, another device. This is HeartMate II, which is what's called a continuous flow device because there is a rotor, and it's axial flow because it rotates around the axis, but the hookup is similar. It's about the size of a D battery and has an external battery source. And when you use that device, you can dial down the pulsatility. You can do that with any of these continuous flow devices. So patients often will not have a systole and diastole. The very first study compared this to the traditional device and found that about over 90% of patients with the device either survived to transplant or had ongoing device support. So the idea of destination therapy is to help people who are not transplant candidates to survive and have better quality of life. And this was the explanation. 35 to 45% of patients die of heart failure within the first year of diagnosis, despite all the good stuff that we have to treat them with, new medications, cardiac resynchronization therapy, defibrillators. And there's limitations to all the therapies that we use. Cardiac transplantation, the major limitation is the shortage of donor organs. So the rationale here is you have an off-the-shelf therapy, which is VAD. You can use it any time without waiting. You can optimize the patients, decide the best time to put the device in. You don't need immunosuppression, and you get people off inotropes. So this is the REMATCH study, 129 patients, 68 with LVAD, 61 with medical therapy. And this is the iconic survival data from this study showing that at 1 year, 50% of the patients with the VAD were alive, and 26% of patients with medical therapy were alive. So the LVAD patients had better survival, quality of life, exercise tolerance, longer hospitalizations, and more adverse events due to the LVAD. The medical therapy patients had worse survival, worse quality of life, and their major cause of death was ventricular arrhythmias. So these are the causes of death of patients, major cause of death of patients who have LVADs put in as destination therapy, sepsis, because you have these external wires coming out, multi-organ failure, stroke, and right heart failure. And stroke and right heart failure continue to be major causes of death in these patients. So a risk score was developed to identify patients at high risk for bad outcomes and death post-transplant. And this is using the HeartMate I, the original device. So low platelets, low serum albumin, a reflection of malnutrition from heart failure, and coagulopathies, manifestation of hepatomegaly and right heart failure were indications of bad outcomes. And if you look at this, you could divide patients into people who were at high risk, who had terrible outcomes, and people who were at low risk, who actually had pretty good outcomes. The other thing that turned out, we used to think that you put these devices in and you unload the left ventricle, so the right ventricle gets unloaded also. And it turns out that it's not the case. So there was a lot of interest in predicting, a lot of these patients would develop right heart failure after getting LVAD. So there was a lot of interest in predicting who could get RV failure. So there are two risk scores. This is the University of Michigan risk score. This is the University of Pennsylvania risk score. Nobody uses these risk scores, including people from the University of Michigan and the University of Pennsylvania. They don't use it. Probably the best risk score that we have is a very simple one, which is CVP over pulmonary capillary wedge pressure ratio. High CVP indicates RV failure, and certainly people with clinical RV failure, hepatomegaly, coagulopathies, are people who are at high risk for RV failure. And when patients go in the OR, you plan to have RV support when they're going in for an LVAD. In the US, we have something called INTERMACS, which is a mandatory database where every patient who gets a VAD gets reported, and they divide severity of patients getting VADs into 7 categories, from patients in cardiogenic shock who have hours to live, INTERMACS 1 to INTERMACS 7, advanced class 3 heart failure. And most of the patients who get VADed nowadays are class 2 and status 2 and status 3. It used to be a lot of the patients were status 1, but people found that these patients would die with VADs or never make it to transplant or would die after transplant. And there's been real interest actually in the US in seeing whether we should put VADs in earlier, and I'll talk about that in a few minutes. These are the outcomes of patients with INTERMACS levels. Levels obviously, level 1 is obviously poorer than level 3. And this is the pivotal destination therapy study comparing the HeartMate II, the continuous flow device, to the pulsatile HeartMate I device. And what it showed was that with a composite endpoint of survival at 24 months, free from disabling stroke or reoperation for device replacement, that there were fewer patients that reached the primary composite endpoint compared to pulsatile flow patients. And looking at the separate markers, Patients with the continuous flow devices were less likely to need reoperation to replace the device, less likely to die, less likely to have disabling stroke, and had better survival. And lo and behold, if you look at the REMATCH study, the survival curve for the LVAD, the pulsatile device, was identical to the survival curve of the pulsatile device used 10 years earlier in the initial REMATCH study. So it wasn't even as if there was a learning curve. And subsequent studies looking at outcomes in terms of survival with continuous flow devices are now reporting one-year survivals of about 80%. So they've improved significantly from what was seen in the clinical trial. So the continuous flow devices at this point, less likely to fail and need to be replaced, less likely to result in stroke, better survival. And they improve hemodynamics, improvement in cardiac index, reduction in wedge, improvement in BUN, they improve end organ function. And this was an important consideration because people thought, well, is continuous flow as good as pulsatile flow? We had a grand rounds given a few days ago at our center where a speaker eloquently discussed the problem with pulseless flow, and we can discuss that as a whole separate session, which was done at the ISHLT. But one thing is in the acute setting of somebody with end organ dysfunction from advanced heart failure, these devices restore and improve function. And in terms of neurocognitive function, they improve function as well. So our center was the core center for the neurocognitive studies for the HeartMate II, led by Ralph Petrucci, our neuropsychologist. And what he showed was significant benefit across the board in a number of metrics of cognitive function as patients progressed after having these devices implanted. But there are significant complications. These people need to be anticoagulated systemically with warfarin. And the issues include gastrointestinal bleeding, hypertension, because you're measuring a mean arterial pressure. We don't necessarily know how to deal with that. There's no systole or diastole, but hypertension in these patients can be fatal. Infection because there is an external wire that goes to an external source. Cerebrovascular accidents are a big problem. Right ventricular failure, and to this I'd add pump thrombosis with a device thrombosis, and sometimes has to be removed. So the etiologies of GI bleeding are from systemic anticoagulation, arteriovenous malformations, which may be due to the lack of pulsatility, pre-existing gastrointestinal pathology, and acquired von Willebrand syndrome, because these devices chew up von Willebrand factor. And the GI bleeding rate reported to be about 28 to 44% annually. Our rates reported to be about 10 to 12% because we run the speeds of these devices lower, so there's less chewing up of von Willebrand's factor. We run anticoagulation lower. This is von Willebrand's factor. This is one of these things that I thought I'd never have to see again after medical school, and lo and behold, becomes important. This is from the group at Columbia, which looked at people on the transplant waiting list supported by a HeartMate II. And what they found prior to transplant is they had diminished von Willebrand's factor and function. And after transplant, they all improved as the device was taken out, and you're no longer grinding down von Willebrand's factor. So reducing GI bleeds, no postoperative heparin, slower RPMs of the device, long-term lower RPMs. This is not a Mustang where you rev up the engine, you want to keep it a little bit lower, and lower warfarin ranges. So the indications are bridge to transplant is somebody who's a transplant candidate on the list who's failing inotropes. And remember, inotropes don't do a good job of keeping people alive for a year. So if you think this patient is going to have to wait for at least a year post-transplant, and in our region would be a big patient who's blood type O, we would often, rather than have them continue to struggle with inotropes, we will VAD them as bridges to transplant. Destination therapy are patients who are not transplant candidates. They're older, and by older we mean maybe in the 70s and above. They have malignancies, they've been treated, but they're not far enough out to be defined as cured. They have active or recent tobacco use. We won't let somebody die if they smoke, but we will not transplant them if they smoke. Poor social support. I want to emphasize, actually, this is kind of an outdated way of thinking, because you need adequate social support if you have a VAD, just as you do with a transplant. So saying, well, the guy doesn't have a family, we'll just put a VAD in, not good thinking. Those people will do terribly, and we've actually seen that. And some patients just choose to have a VAD. We had a lady who was supported for 10 years, and she just kept on saying she was not interested in transplant, and she did fine for 10 years with a VAD. So we sometimes call this a bridge to decision in people who are not ideal transplant candidates. Our federal government doesn't like us to use that term. They want us to say either patient is destination therapy or bridge. In Europe, they do use the bridge to decision designation. So when to refer, and this is something that drives us crazy when we have somebody send us a patient who's moribund, oh, can you put a VAD in? They can either walk only one block or you think they have 1 year to live. They're intolerant to beta blockers or ACE inhibitors, not due to cough, but you can't increase the doses to significant levels because they get hypotensive. They've had hospitalizations for heart failure, at least 2 in the past year, despite being on appropriate medications. They don't respond to cardiac resynchronization therapy. They need inotropes. They're hyponatremic. They have renal insufficiency. They have an elevated LVEDD. And this is, and if the disease progresses on appropriate medical therapy or people who can't tolerate it, these are reasons to think about it as well. And then the Center for Medicare and Medicaid Services says they have to be class 3 or class 4. Usually they're class 4 with a low EF, and they have to have significant functional limitation for at least 45 of the last 60 days, despite use of maximally tolerated drugs. This is a lady who's had a HeartMate II more than 8 years. It's been 10 years. She's not our patient, still going strong. And this shows the risk of developing complications in the clinical trials versus post-approval studies. So there's less infections, less bleeding requiring surgery, less pump replacement, ischemic stroke, hemorrhagic stroke, and about no difference in thrombus. So people with experience are better able to handle these devices. And there are probably close to 10,000 patients supported with the HeartMate II. And this shows that in the US, the number of VADs being put in has exceeded the number of transplants. Now that includes bridge to transplant destination therapy, but I think within the next 2 to 5 years, we'll be seeing more DT patients than transplants. What are some of the other devices? This is the JARVIK 2000, not approved for use. It's still in clinical trial. And actually, the outcomes have not ever been reported. This device is almost entirely intracardiac. This is the guy who previously had the longest support. He died of multi-organ failure. Here he is putting his thumbs up in front of the Capitol building. Sort of looks like Donald Trump, except his hair isn't orange. And then this is another device that is used and approved as a bridge to transplant, but not destination therapy. This is the HeartWare device. This is a centrifugal flow device, but a continuous flow device. It goes into the left ventricle with a cannula going to the aorta. And it was compared to the HeartMate II in a very strange study. They looked at a population of patients who got the device and compared it to the contemporary INTERMACS population, the federal registry, who got VADS for clinically indicated purposes, mainly HeartMate IIs. And so what they found was similarity in terms of patient profile and severity of heart failure, and the survival at transplant or still alive was similar to what was seen with the HeartMate II. And the control and HVAD populations were similar. So it was now approved as a bridge to transplant. There's a study called the Endurance Study, which is looking at destination therapy. And that study was troubled by increased stroke and mortality, which was felt to be due to hypertension and due to a flaw in the device. So the device was re-engineered during the study. A new protocol was established to manage hypertension, but there still is an issue with stroke, so that it's not clear this will be approved for destination therapy. This is our former Vice President, Dick Cheney. I show him because he was supported with a VAD as a bridge to transplant, He was transplanted at age 71, which is a little bit older in the U.S., but suddenly every single patient that we had who was older than 70 said, can we get a transplant because Dick Cheney got one? The number of VADs being put in goes up. This is worldwide from the ISHLT. It's now approached 50% as bridges to transplant. And this is the number of destination therapy VADs, number of bridge to transplant. So there are more DT VADs than there are bridge to transplant VADs. And there's been a thought that maybe we should put VADs in patients who are less sick. So, for example, the INTERMACS 4, 5, 6 groups. And there was and those patients really are not getting VADs at this point. So there was a study called RoadMap. There were two studies. One was Revive It, which was never started because they had so much difficulty enrolling, and they've tried to revive It, but it's been unrevivable. So RoadMap was completed, and what they found was that people who got the VADs maybe had better quality of life. It's not clear they had better survival. People who were not randomized to get VADs often had an acute need to get a VAD. But it's not clear at this point, and this was an industry-supported study, it's not clear at this point that patients who are INTERMACS 4, 5, and 6 should get VADs. And so this shows the number of patients who are sick enough to need VADs. It may well be, for destination therapy, it may well be 90,000 patients in the U.S. who ultimately would need, on an annual basis, destination therapy VADs. There is a new VAD. Dr. Hankins will talk about the HeartMate III, which is studied in the Momentum study compared to the HeartMate II. Less stroke, less pump thrombosis. And in Europe, where the HeartMate III has been approved for use, the HeartMate II has disappeared. So we'll see what happens in the U.S. This is the ideal, what's needed for an ideal VAD, minimally invasive implantability, durable use, totally implantable, so no external wires. So basically, forgettable power source, easy to implant, modular replacement, hemocompatibility, so there's no stroke, BiVAD support, weanable, and affordable. And we're not there. This is the HeartMate III, which is the newer device. And these are some of the smaller devices that are being developed. This is the Circulite, which is put in percutaneously. It can only provide relatively limited cardiac support and was associated with thrombosis in the clinical trials. This is the next HeartWare device, which has not started clinical trials. And this is an even smaller HeartMate X. And so these are some of the devices that have been used. DuraHeart has disappeared. This is a percutaneous temporary device, and this is used for RV dysfunction. This is the device that may ultimately be, it's not developed yet, but may ultimately be totally implantable, which means you reduce the infection risk. So this decision tree for elective mechanical circulatory support in advanced heart failure, high RV failure risk. Some people say supportive therapy, cardiac therapy, but not a VAD. But low RV risk, you'd put in a VAD. And if there are risks that are reversible, it would be considered a DT VAD. I showed these criteria. So there's still an underserved advanced heart failure population that will benefit from VADs. We need innovative ways to address the growing VAD patient population, make it more cost-effective. There's a need for smaller, more easily implantable, durable, totally implantable VADs. Patients should be able to forget that they have a VAD because it's so unobtrusive. And we need to show in less sick patients that this provides a benefit. And the other interesting thing is that VADs may provide a platform of MCS to allow stem cell and gene therapy to enhance recovery. And that's all work that's underway. Kamsahamnida.